Bismillahirrahmanirrahim. Now one video station on respiratory and the video station in the video. How can we do the video station? Because we have 3 minutes time and we can start the describe the age. If name is mentioned, that I can found in the video the child is, we can mention the settings, and then the child is ill looking or well alert, and then is there any dysmorphic face present or not, and is there any device present or not, and in general examination findings, and then local examination findings. So in the video I can see a 5 months old boy in hospital settings, looking unwell, alert, and he has no dysmorphic face. He is suffering from there is IV cannula and oxygen tube in situ, and I can hear the monitor sound, and there is severe respiratory distress in the form of fast breathing. However, I want to count the respiratory rate, and intercostal subcostal recession is present, but I can't appreciate any cyanosis. And I can also hear there is audible wheeze and cough is present. So my differential diagnosis: bronchiolitis, viral induced wheeze, pneumonia, pertussis, cystic fibrosis, gastroesophageal reflux disease, heart failure, and congenital lung anomaly, congenital heart disease. So the history will be onset, course and duration. Is there any prodromal phase present or not preceding this illness, and what is there any fever, any weight loss, and what about his activity, and is there any blue coloration, any apnea, and any fits present or not, any sweating while feeding present or not, and then what about the feeding history and urine output, and then in perinatal history, is the term or preterm, any hospital needed after delivery or not, and any family history of heart disease, and any home environment, especially smoking history, exposure to passive smoking or not. And then examination, airway, breathing, circulation, vital signs, anthropometry, SpO2, and is a dehydration present or not, and respiratory system examination, cardiovascular system examination, and para-abdomen examination for visceral glossoptesis, or the liver is pushing to the down or not. And then what investigation if it's a case of bronchiolitis. For bronchiolitis, there's 2 investigation. Basically, this is SpO2 and capillary blood gas analysis, and if when we prescribe capillary blood gas, if there is severe respiratory distress, fast breathing, respiratory rate is more than 80, transcutaneous partial pressure of carbon dioxide more than 6 kilopascal, and SpO2 is less than 90 with more than 50% inspired oxygen. And beside these 2 investigation, other tests not required, but if this is required, we can say this is nasal swab, paranasal swab for viral respiratory syncytial viral serology, if by PCR, if there is a high prevalence of flu, or there is comorbid immune compromised child where we are planning for giving antiviral medication, and also urea electrolytes if we are planning to keep the baby nothing by oral, and blood culture if the child is having a sign of sepsis, or there is temperature is more than 38.5 degree Fahrenheit. Chest X-rays if there is a localizing sign present, or any cardiac murmur, or there is atypical presentation, child is more than 18 months. management, immediate management and subsequent management follow-up. Immediate management, if there is severe, the child having severe respiratory distress, so immediate admission, airway, breathing and circulation, and first of all the general management, we will manage the child in cubicle or the same area having the patient of the same diagnosis, stick hand washing and wearing apron, and we will nursing the child in head up position, and we will give the suction. Before suction we will provide 0.9% sodium chloride nasal drop, and then the respiratory support by oxygen inhalation by nasal marks, by oxygen marks if it is not tolerant, so nasal oxygen. If it is not tolerant, if the situation is still low, so humidified or high flow oxygen, and if it is not improved, so CPAP. And then feeding and hydration, circulation and hydration, we will monitor this hydration, and we will provide the child IV fluid. If shock, we will correct the shock immediately, and we will give 80% of the estimated amount of the fluid. And feedings, we will provide normal feed if indicated, NG2 feeding where the normal feeding is not tolerated, and patient can tolerate the NG2 feeding. If there is severe respiratory distress and persistent vomiting and oxygen saturation is less than 90% with supplemental oxygen, so we will give the patient only IV fluid. And medication, we don't provide any kind of medication. We only can provide oseltamivir for influenza. If the influenza test is positive and the symptoms is less than 18 hours, and there is risk factor for respiratory, renal, liver, neurological, cardiovascular, diabetes, or immunocompromised, so we can prescribe oseltamivir. And we will provide antibiotic if the child age is less than 6 weeks and temperature is more than 39 degrees centigrade. And this is the acute management, subsequent management, fluid balance, and oxygen support, and wins oxygen when indicated. Indication and then follow-up. Follow-up, we will discharge when the feeding is established and he can maintain oxygenation more than 90% with room air. And GP follow-up, all the cases except hospital follow-up. Hospital follow-up when the child was ventilated in PICU or there was a consolidation in the chest X-ray. And indication of hospitalization, absolute indication if there is apnea, underlying cardiac disease, feeding difficulty is present, diagnosis is uncertain, and there is dehydration is present, and oxygen inhalation less than 92% in a child in the early phase of illness. And relative indication for admission when the age is less than 6 weeks, difficulty in the family circumstances, and impaired ability to take care of unwell child. And if the child is younger enough, earlier in the illness, and pre-existing chronic disease such as neurodegenerative disease, and pre-existing lung disease such as ex-preterm cystic fibrosis. Thank you. Assalamu alaikum.